Thank you to the organizing team for giving me this opportunity. But anyway, so currently today I'm going to discuss about the Radicals HD, the most awaited trial in terms of hormone therapy in post-operative prostatic cancer with radiotherapy. So Radicals was actually a trial which was planned to see two different aspects. One is whether radiotherapy immediately or should we do radiotherapy after there is a biochemical recurrence after radical prostatectomy. And the second component of this trial was whether hormonal therapy in post-operative setting with radiotherapy had any benefit in the long term. So basically, Radicals, as I said, is radiotherapy and androgen deprivation therapy, and its chief investigator is Dr. Chris Parker from Royal Marsden. So as you can see, there is the first randomization that is between the timing of radiotherapy, that is whether we have to treat them immediately versus salvage, and this is mostly seen in post-radicals radical prostatectomy setting. And the second randomization was whether the hormone had to be 6 months or long term, that is 2 years, or what there was there any benefit with giving hormone therapy at all. So the hormonal therapy arm had again further two randomization, whether we would plan for at the time of radiotherapy for 6 months versus long-term hormone therapy. Whereas there was another randomization, that is 3-arm randomization, where patients were also put into radiotherapy alone arm, 6 months alone arm, and 2 years hormonal therapy arm. So this bias was basically inherent because the selection of choosing with 6 months versus long-term radiotherapy arm versus no hormonal therapy arm and 6 months arm was invested with the patient's physicians based on the clinical risk factors and other surgical and pathological factors. So the trial specifications it was originally planned for 12 to 13 years. The primary outcome measure was actually changed to freedom from metastasis down due to low event rates. The original primary outcome was disease-specific survival, but they didn't achieve the expected events within that span of 7 to 10 years. So they had to change it to freedom from metastasis-free survival. So probably, the statistical methods also suggested that it was powered to say that. And the secondary outcome measures were time to salvage of androgen deprivation therapy and overall survival. The androgen deprivation therapy used here was both LHRH agonists, that is leuprolide, and bicalutamide. But except in Canada, because it's a multi-institutional study, Canada did not have the license for this setting. So in Canada, it was mostly LHRH agonist, whereas rest of the institution had the choice of making between bicalutamide versus LHRH agonist. So as you can see, the inclusion criteria, obviously the post-operative PSA should be less than 0.2. As per Radicals radiotherapy trial arm, the biochemical failure was considered to be 0.1. And ideally, it should be more than 4 weeks and less than 22 weeks after radical prostatectomy, the introduction of hormones. And one or more of the high-risk features, that is PT3, 4, or Gleason 7 to 10, biopsy or surgical sample, preoperative PSA more than or equal to 10, and positive margins. These were the high-risk features. Patients due to receive postoperative RT either early or deferred later for salvage radiotherapy would have been randomized at that point in time when they would have planned for radiotherapy. Exclusion criteria was any previous bilateral orchidectomy, prior pelvic radiotherapy, any other active malignancies, no distant metastasis from prostate cancer, preoperative hormone therapy within previous 6 months, and any previous hormone therapy longer than 8 months, any post-operative hormone therapy, and PSA more than 5 at the time of randomization. Most importantly, the staging method, what they used was the standard bone scan and CD chest abdomen pelvis. Mind you, they did not use PSMA PET or MRI for that matter. So the trial methods, it's again multi-institutional, multi-centric international phase 3 randomized control trial, mostly Denmark, UK, and Canada. The radiotherapy arm had recruitment from Ireland as well. The representation of Ireland in hormonal therapy was lower. The trial period was from 2007 to 2015, a total of 2,839 patients, whereas 492 patients underwent the 3 randomization arm, although this has not been yet discussed in the current abstract because we are waiting for that result. Whereas what they have published currently is 1,480 patients who were randomized between none versus short-term hormonal therapy, which is about 6 months, and 1,523 patients data, which is short-term, which is 6 months, and long-term hormone therapy, which is again 2 years. So the assumption to even begin with this trial was, how did they get these numbers? It's because they thought that there is about 6% absolute benefit between the disease-specific survival for people who are undergoing hormone therapy after radical prostatectomy with radiotherapy. And with this number, they thought they would require about 1,500 patients for a trial running for about 7 to 10 years. The sample size also incorporates about 30% of loss to follow-up in 5 to 10 years, which is a standard statistical method which they use for a long follow-up trial. So this is the current patient characteristics which they have reported. That is last year in ESMO. So the 2 randomization, the 3rd randomization they have not reported yet. So the 2 randomizations, none was short and short versus long. So what you can see is the median age is about 66 and PSA is standard about 0.22 in both arms. They've matched mostly. But what you can see is the high-risk features, especially the Gleason 810, pathological staging T3B and 4 positive margins, are quite more common in the short versus long arm. That means there was an inherent bias among the clinicians to recruit these patients in the hormonal therapy with radiotherapy arm. So you can see that representation is fairly minimal in terms of none versus short, because randomization was completely computerized, so you never know whether your patients would be landing up in a hormonal therapy, which I think the clinicians had their bias with. So there was a selection bias to some extent. Obviously, so as the results have been published, the results say that there was about metastasis-free events in none versus short term, which is fairly a better group in terms of clinical pathological staging. And they saw about 268 events, that is metastasis-free survival events. Hazard ratio was 0.89. It was not significant because the confidence interval is crossing 1. Whereas the short term versus long term, you can see that the hazard ratio is 0.77 and not crossing the significant. I mean, it is significant because there is about 313 events and confidence interval is below 1.0. And even free survival at 10 years, whereas none versus short was about 79 versus 80, not much of a difference. Whereas there was about 6% difference. Actually, that was the assumption, what they made, even at beginning of this trial, that they were looking for a 6% benefit for this trial to continue. And I think they found that in the short term versus long term arm. Now, time to salvage, the ADT was about 0.54 hazard ratio, again significant. And even in the short term and long term, there was about 0.73, and confidence interval was 0.59 by 91. So in essence, there was about 27% difference. And overall survival, as you can see, it's identical in both the arms. So what they are saying is there's no overall survival difference between hormonal therapy arm versus none, and also short and long arm. What they are trying to tell is the metastasis-free survival events have been better in short versus long-term arm, and even free survival is improved. So in essence, we are not improving overall survival, whatever hormonal therapy we are using. But in essence, metastasis-free survival events can be reduced in people who are having longer-term hormonal therapy. So the conclusion actually by authors is in patients having post-operative radiotherapy after radical prostatectomy, 24 months ADT versus 6 months ADT improved both time to salvage ADT and metastasis survival. But in contrast, the 6-month ADT did not. They didn't pay more attention to the overall survival because we are still yet to receive rest of the data yet to be published, that is toxicity data, secondary events, and they still need more events to complete and mature to comment on overall survival. But currently, yes, there is no overall survival benefit as per the current published data in terms of hormonal therapy with radical prostatectomy. So I think rest of the questions we can have at the panel. Thank you.